Thank you for taking a moment to answer the questions in your journal. We'll get into the actual answers as we go through the next part of the lecture, but let's take just a moment to look at what some of the common responses are to these questions. The first question is, what does a mentally ill person look like? Well, if you're like most folks that answer this question in a classroom setting, you said something like the person's behavior may stand out as being unusual. Perhaps their dress, their communication style, or their mood state may seem unusual or out of sorts. When the truth is that most mentally ill people look just like you and I. On an average day-to-day basis, you're likely experiencing people who are receiving treatment for mental illness. The statistics are clear. 1 out of every 5 people will experience a mental health diagnosis in the course of their lifetime. So it's not that unusual or even abnormal to be mentally ill. The folks that you are referring to, if you thought those sorts of things, are out there. They do experience mental illness, but they aren't the typical mentally ill person. And it's important for us to understand that mental illness is difficult to define as typical in the same way as we might say physical illness is difficult to define. It's a very broad term, just the same way as we might say physical illnesses explain everything from colds to cancer. Mental illnesses are similarly broad. So we'll talk a little bit more about having a more specific and illuminated view of mental illness as we go through the course. But it's perhaps an understanding, that a fundamental understanding for us, that people who are experiencing mental illness don't normally look very much different than you and I. The only people that might recognize something different are often the person's closest family, friends, and their doctor. What causes mental illness, and when is it most likely to occur? Well, we're going to look at these answers more in a couple of slides, but it's important to understand that what we're starting to understand about the causes of mental illness is evolving. Many people will answer things like trauma, genetics, drug and alcohol use, and the answer is yes. All of those things seem to play a role. But one key word that we want you to take away from this course is understanding convergence. The idea that one factor on its own probably isn't enough to ignite or cause mental illness. That more likely what's happening is a convergence, or the way that some of the factors in a person's life are connecting. And we'll talk about when it's most likely to occur in just a moment. What happens to most people who are diagnosed with a mental illness? Of all the questions that we ask, this one perhaps is the most revealing of some of the preconceptions that we have coming into the room. In fact, most people tell us that people who have mental illness start to experience some significant decline in the quality of their life. They may be isolated from family and friends. Their job may be in jeopardy. Their self-esteem may deteriorate. And they may lose some of who they are as they go through treatment. The truth is that most people who experience mental illness recover. Most people either get better and return to a better quality of life, or at the very least learn to manage or compensate for their mental health symptoms the same way as a person with chronic physical ailment might do. A person who's intolerant of a substance, for example, might learn to live around that substance. So it's not necessarily easy, but it is quite possible for people with mental health needs to lead a very full, functioning, and high-quality life. How are mental illnesses diagnosed? They're diagnosed according to a strict set of criteria that are outlined in a book called the Diagnostic and Statistical Manual, or DSM for short. So you may recall that one of the questions that was asked in the pre-assessment is there a strict test for mental disorders? And you might be surprised to find out that the answer is yes. Each of the diagnoses that a person can be given has a very specific set of criteria against which the clinical professional is supposed to compare. Now, sometimes clinical professionals move outside of those criteria, or even create diagnoses that are not really recognized currently. But we're going to talk more about that in a moment. Now, this DSM is created by the American Psychiatric Association, and it has been written since 1952, but it's been revised or rewritten every 10 to 16 years along the way. And we are currently using what's called the DSM-4 TR, which means the Diagnostic and Statistical Manual 4th edition, and that 4th edition has had a text revision, that's where the TR comes from, even since it was created. Now, we expect the DSM-5 to be released in only May or June of 2013, so as we sit here taking this course, some of the things we're talking about may be revised even in just a few months. because disorders can be added, deleted, or changed from the book based on input from very large committees that are used to help write the diagnostic manual. And those committees are formed by clinical professionals from all around the United States, the rest of North America, and even the world. And in some cases, there are hundreds or even thousands of psychiatrists and other clinical professionals giving their input on each disorder. Perhaps the most famous example of a disorder being deleted was homosexuality, which was originally identified as a mental health diagnosis in one of the first versions of the DSM. A more recent change is the way that the views around autism are likely to change the way that disorder is notated and diagnosed in the DSM-5. Right now, it's diagnosed as something called a pervasive developmental disorder. But what's likely to happen is that some of the trends in the field will be reflected in the new naming. It's going to be called an autistic spectrum disorder, and clinical professionals will be able to say that an individual has more degrees of autism or less degrees. Now, this is an important thing to recognize because the clinicians that are contributing to the book aren't just doing so based on mere guesses. They're doing it based on their own professional experience. They're reflecting on what they see coming through the door into their offices. And that in turn reflects much of what the community is concerned with, what the community considers to be an issue. And this is how the book has been revised. Now, the DSM uses something called the multi-axial classification system. And I realize that that sounds very complicated, but in fact it's actually a fairly simple system. And what it's designed to do is have the doctor look at the individual as a whole person instead of just looking at their mental disorder. The mental disorder is just the first of 5 different axes upon which the physician is going to make notations. The others that they're going to look at will include things like the individual's medical and physical condition, and their social and environmental factors, because as you might imagine, those things, a person's physical health and what's going on in their social existence and their environmental existence, will play a role. For example, if a person was homeless or if a person was suffering from diabetes, each of those things might play a role in a person's mental well-being as well. One of the other axes is kept aside for 2 specific diagnoses, and these deserve to be spoken about for just a moment. The first one is developmental disability. Now, developmental disability is not what the current DSM refers to it as. They call it by the very old school term mental retardation. Now, it's not a term that you're going to hear very often in Canada anymore at all, partly because it's not seen as a very accurate reflection of the disorder, and also partly because it's considered to be a very stigmatized and undignified way of speaking of people who have developmental disabilities. So you are more likely to hear the terms developmental disability, intellectual disability, or cognitive disability now to mean that same thing. And personality disorders will also be on this separate axis. Personality disorders are best described as distortions of personality. So they include things like, for example, a person who's particularly antisocial, particularly shy and avoidant, particularly emotional, particularly concerned with structure and order in their lives. Those are just 4 examples of the 10 personality disorders that are currently recognized. Now, the reason why these disorders are kept separate is because they have specific implications for the treatment of the mental illnesses. They are pervasive, they affect all aspects of the person's ways of thinking and socializing, and we typically don't expect to see the person's condition change or be cured in the course of their life, unlike, for example, a person who has something like major depressive disorder, and where our intent would clearly be to see that person recover. What are the causes of mental illness? Well, the truth is that the causes are not completely understood. Research continues, but we have to keep our minds open. One thing that does seem to be apparent is that it's not just one single factor that causes mental illness. We understand that the most common time for the onset of mental illness is the adolescence and young adulthood of people, that age period between the ages of 17 and 35. I want to stress that this isn't the only time when mental illness occurs in a person's life. For example, disorders such as autism are normally recognized before the age of 3. Attention deficit and hyperactivity disorder has its signals shown before the ages of 18. And we normally think of something like dementia of the Alzheimer's type as being associated with people who are aging, 65 and older typically. But this particular time of life, called adolescence and young adulthood, seems to have the highest incidence, particularly of disorders that are tic disorders, psychosis, including schizophrenia, and mood disorders such as major depressive disorder. And I like to look at this particular stage of life because it gives us a little bit of an insight into how the physical changes in the person's body can combine with what's going on with them in the social environment and give us an idea of convergence. So think about it for a moment. During the time when you were in your early teens, maybe only 10 or 11 years old, chances are that you moved both figuratively and literally from the child's table to the adult's table in life, and suddenly saw a loss of innocence. Things that you'd been sheltered from, such as what was going on in your parents' marriage or the finances of the family, might have been less hidden away from you. And the same thing about as with regard to things going on in the outside world, some of the ugly stories that are on the news. But when we have that loss of innocence, it can be difficult for us as adults to remember what it was like to see the world through that young person's eyes without having developed a filter or sort of a way of buffering some of that bad news and being able to manage it. And so it can hit a young person particularly hard. Of course, the use of drugs and alcohol can also be a significant impactor on a young person. Not only is that something they're going to develop social values about, but as they're utilizing those substances at the same time as their body and their mind are going through dramatic changes, they may be experiencing more lasting effects than they might understand. And the research shows that, for example, marijuana use in youth is correlated with a higher incidence of psychosis and a form of psychotic development that may be more difficult for that young person to either grow out of or manage later on. Similarly, alcohol use is correlated to depression in a similar way. And another thing that might be happening in the person's life is just a lot of life stress. Think about that period of time between your about 17th and 25th years. Chances are you graduated from school, had to go off and start a career or get an education. Perhaps you experienced debt, having to make an income, living on your own. Perhaps you got into a marriage or had children, all in that span of time. If you think about it, that's a tremendous amount of flux and stress and responsibility. And for me, it's a perfect example of what we mean when we distinguish between trauma and stress. Many people are asked, when they are asked about what causes mental illness, automatically think of traumatic experiences, like, for example, rapes or wars. Now, some people do experience mental health issues as a result of going through trauma, but most people don't have that as a correlate. However, when we look at what causes mental illness, for many people, it's an overwhelming feeling of being stressed, of having too many things, more than they can manage. And yet one person may look at the amount of stress that individual is experiencing and think, I could have managed that. So we have to understand that it's not just the amount of stress that matters, it's the coping mechanisms of the individual who is stressed. What were they given in terms of resources, in terms of their schooling, their parenting, or in terms of things as simple as their own physiological, their cognitive ability and their physiological ability? Some people are better equipped to deal with certain amounts and certain types of stress than others. Genetics also play a role. But we've always been taught about genetics in the sense of our heredity, things that are passed down from one generation to the other that form a blueprint. And we need to change our way of thinking about genetics a little bit in order to understand how they play a role in psychology. Because we understand now that if your grandmother or your mother was, for example, schizophrenic, it doesn't automatically mean that you are going to be schizophrenic as well. Instead, it seems as though there is an improved likeliness, a higher probability that you will have that same disorder. And that predisposition, as opposed to predetermination, has a fancy name. It's called diathesis. Diathesis simply means that you carry a gene that makes you more likely to have a particular symptom, characteristic, or behavioral trait. And it's called predisposition or likelihood as opposed to predetermination. But that diathesis, that likelihood, has to be turned on by something. And it seems as though what's turning it on is stress. So diathesis and stress together get a fancy name, diathesis stress mode. And a classic example of this is alcoholism. We know that sometimes children who are born of alcoholics don't go on to become alcoholics even though they possess the gene that makes that particular disorder more likely. But some do. And what's the distinction? Well, it looks as though in some cases the distinction is whether or not things have happened in their life that can ignite that particular gene. These things that happen are largely in what we call the psychosocial category. In other words, experiences that we have socially that influence us psychologically. Again, some people have identified trauma as a psychosocial influence, and indeed trauma can be very, very powerful as a cause of mental illness. It can, for example, cause acute stress disorder or post-traumatic stress disorder, PTSD, that you see on your screen. But stress seems to be the real culprit, and stress, I gotta emphasize again, is not necessarily the same from one person to the next. It really has to do more with what the internal resiliency is of the individual experiencing that stress. And where do we develop that resiliency? We develop it largely through our personality development, from our family, from our teachers, from our social circle. So what we don't get there can be as important a thing to be passed down to us by our parents and by previous generations as genetics. And so this is why things can look as though they're happening generationally. In fact, they are happening generationally, but they aren't necessarily happening genetically. And we can't forget as well about the possibility that a mental illness can be caused by an injury or disease, such as a brain injury. And chronic simply means something that happens in an ongoing way. For example, I worked with people who had epilepsy. Now, the epilepsy itself didn't cause brain injury, but in the case of some of the individuals I worked with, they fell so many times in their life that after each fall, they sustained a little bit more brain injury, and eventually this had an effect on their mental health. Or it can be an acute or sudden onset type of brain injury, such as a fever or oxygen deprivation, for example, from somebody who's drowning, or a head injury, such as from a car accident. It might also be from the exposure or even a single use of a particular substance. That substance could be a drug, including a prescription drug, or it could be something like poison or fumes. And of course, diseases can cause a person to have mental health issues. For example, depression is highly correlated with heart disease, and scientists seem to believe that it has to do with the flow of blood regulated to the brain. And aging as well can cause things like mental disorders such as Alzheimer's disease, as discussed. But the most important thing to understand is that most people who are experiencing mental illness have a combination or convergence of these effects. It's not likely that just one single factor on its own will cause a person to experience mental illness. Now that we've talked a little bit about the causes of mental illness and what its definition is, I'd like you to take just 3 minutes to write in your journal, answer the following questions, and review your responses with your partner or compare your journal entry with that of others. This is a very short write, just 3 minutes altogether. The first question you're asked is, what factors determine in your mind when a person's thoughts, feelings, and behavior become mental illness? And the second question is, what factors make those same thoughts, feelings, and actions seem understandable and contextual to you?